This patient presented with palpitations, and what we see here is a narrow complex regular tachydysrhythmia. It could be sinus tachycardia, it could be atrial flutter, or it could be SVT. Differentiating SVT from sinus tachycardia can be a challenge, but the couple of things that we're looking for is the absence of P waves in SVT and exquisite regularity. With sinus tachycardia, you're going to see some variation around the rate, but with SVT, it's going to be 180, 180, 180. You're going to leave the room, grab a cup of coffee, do a thoracotomy, come back in the room, and the patient is still going at 180, 180, 180. Once you've made the diagnosis, there's a couple of things to keep in mind in terms of management. Number one is that we shouldn't routinely be sending troponins for these patients. There's a good amount of literature showing that SVT is not a presenting dysrhythmia in ACS, and these troponins can actually lead to increased downstream testing, which can harm the patient. If the patient is stable, most of us would reach for adenosine, but adenosine is a crappy drug. It makes the patient feel terrible, and there is a significant recurrence rate after breaking them with that adenosine. We have a better option, which is calcium channel blockers. I'm reaching for diltiazem 0.15 mg per kg, and the data here shows that it is as successful as adenosine in breaking the rhythm. It is much better tolerated by the patient, and it's less likely that the patient goes back into SVT after getting that DILT.